was pre-operatively, and this is how it is post-operatively, almost 6 months down the line. So, like, save the head. I think it is possible not to jump to, replacement surgery in young people, but that's a long-term bearing.
Thank you, Dr. Maheshwari. We are very short of time, so
Okay.
just, please.
Okay, that's all right. I can finish it here, no problem.
Thank you, sir. Thank you.
Right. Thank you. Bye-bye.
Thank you, sir.
I'll stop share.
Thank you, sir. So nice, but we are short of time, so
No, that's
I
okay.
apologize.
Okay.
Our next speaker is Dr. Govind Sethi. He is an alumnus of MLB Medical College, Jhansi. Worked at Kanpur, his home city. Then, along with the late Dr. P.M. Gadre, and then settled in the United Kingdom. He has worked in many hospitals, to name a few: Calderdale Royal Hospital, George Eliot Hospital. Worked with Mr. Copeland, world-renowned surgeon who invented Copeland shoulder arthroplasty in Reading. He has also worked with Dr. S.C. Haldar, who invented the gamma nail. Now he works as consultant in Calderdale and NHS Trust in Yorkshire, United Kingdom. His main interest is in lower limb arthroplasty, knee arthroscopy, and trauma. His topic for today is ipsilateral fracture neck radius with comminuted intra-articular fracture distal radius with comminuted fracture proximal ulna with carpal tunnel syndrome. Dr. Sethi, please share your screen.
Okay, can you hear me?
Yes.
Okay, thank you so much for having me part of this webinar. First of all, thank you to Uttranchal Orthopaedic Association and giving me an opportunity to presenting this case and to be sharing my dice, though virtual, with the learned faculty of India, from whom I'm going to learn a lot today. Now, this is a presentation case which is not very commonly seen. I was on call when I got this patient. This patient is a 41-year-old lady who sustained injury while she was on a step stool trying to clean the spider web from the roof. Came to casualty with swelling, deformity in left forearm. She's complaining of pins and needles on the left hand, typical of a carpal tunnel. No injury to the posterior interosseous nerve. The vascularity of the left forearm was intact and the injury was closed. A word about her lifestyle. She's slightly overweight. She's a non-smoker. She drinks alcohol within the social limits. And the only other comorbidity is an underactive thyroid. So what do we do? When she came, the actions taken were give her a bit of analgesia and send for an X-ray. And the X-ray findings proved to be that she's got a left comminuted fracture intra-articular distal radius, fracture left comminuted metaphysis of the proximal ulna, which is not Montagia, but Montagia-like lesion. I won't call it the Montagia variant as well, but the Montagia-like lesion, along with the fracture left comminuted neck of radius, all on the same forearm. I've never seen it before like that. So as we know, the proximal radius and distal radius fracture form a common injury of the forearm, accounting to 14 to 17% of all adult extremities. But this is pretty rare fracture, and naturally, the treatment will depend on how to age and the demands of the patient. The management is not universal. The management for a lady with a 90 years would be definitely different than somebody of 41 years of age. These are the X-rays I want to share with you. If you see the two columns of the wrist is not congruent, she's got a fracture intra-articular distal radius. And that's a lateral view showing the dorsal combination of the distal radius fracture. And that's the proximal ulna with the metaphyseal fracture with the fracture neck of radius, which